Let's talk about dexmedetomidine. Of all the drugs we use in anesthesia and critical care, dexmedetomidine might be the most pharmacologically elegant. It provides analgesia without opioids. It blunts the sympathetic nervous system without causing respiratory depression. Patients sedated with dexmedetomidine can be woken up, answer questions, follow commands, and fall back to sleep when you stop stimulating them. It is not a perfect drug. The bradycardia can be significant. The hypotension is real. The onset is slow. Amnesia is not assured. But when you understand exactly what it does and exactly who it is for, dexmedetomidine becomes one of the most valuable tools in your entire clinical arsenal. Let's go through all of it. Chemistry and formulation. Dexmedetomidine is a highly selective, specific, and potent α₂-adrenergic agonist. The α₂ to α₁ receptor selectivity ratio, approximately 1,620 to 1. This extraordinary selectivity is what defines dexmedetomidine's clinical profile. Compare this to clonidine, the older α₂ agonist, with a selectivity ratio of only 220 to 1. Dexmedetomidine is 7 to 10 times more selective for α₂ receptors than clonidine. And unlike clonidine, which is a partial agonist at the α₂ receptor, dexmedetomidine is a full agonist. More selective, more potent. Full agonist. Shorter duration of action. This is why dexmedetomidine has largely replaced clonidine for one-fee use in anesthesia and critical care. Chemically, dexmedetomidine is the dextrorotatory isomer, the active enantiomer of medetomidine. Medetomidine has been used in veterinary medicine for years for its hypnotic, sedative, and analgesic effects. Dexmedetomidine is the pharmacologically active component. Formulation: 200 micrograms per 2 milliliters. Concentration: 100 micrograms per milliliter. Water soluble. No lipid emulsion required. No preservative. For one-fee use only. Mechanism of action. Dexmedetomidine works by activating presynaptic α₂ receptors, which inhibit the release of norepinephrine. The result? Sympatholysis, a reduction in sympathetic nervous system activity. Let's trace the anatomy of this effect. The locus coeruleus, located in the pons, is one of the highest densities of α₂ receptors in the entire brain. The locus coeruleus is the brain's primary norepinephrine-producing nucleus, a critical modulator of vigilance, arousal, and sympathetic nervous system innervation of the forebrain. When dexmedetomidine activates α₂ receptors in the locus coeruleus, norepinephrine release is inhibited, sympathetic tone decreases, the patient becomes sedated. But the quality of this sedation is fundamentally different from GABA-mediated sedation, benzodiazepines and propofol, which cloud consciousness and can cause paradoxical agitation and tolerance. Dexmedetomidine produces a natural sleep-like sedation. The EEG pattern resembles stage 2 sleep, sleep spindles, not the burst suppression or diffuse slowing of anesthetic depth sedation. The patient is calm, quiet, sedated, but can be aroused with stimulation and will fall back to rest when stimulation stops. At the spinal cord, specifically the substantia gelatinosa of the dorsal horn, α₂ receptor activation reduces substance P release, producing analgesia. This is the mechanism of dexmedetomidine's analgesic properties. α₂ receptor subtypes. For boards, 3 subtypes matter. α₂A receptors, sedation, analgesia, sympatholysis. These are the primary clinical effects. This is where dexmedetomidine exerts most of its benefit. α₂B receptors, located on peripheral vascular smooth muscle, responsible for the transient vasoconstriction and hypertension seen with rapid bolus administration. This is the initial cardiovascular effect, before the central sympatholytic effects dominate. α₂C receptors modulate mood and cognition, minor clinical relevance for routine anesthesia practice. Pharmacokinetics. Distribution. Highly protein-bound, greater than 90%, bound to albumin and alpha-1 acid glycoprotein. Rapid distribution. Distribution half-life approximately 6 minutes. This explains the relatively rapid onset of effect after bolus administration, despite the recommendation to give loading doses slowly. Metabolism. Extensive hepatic metabolism. Glucuronidation and CYP2A6-mediated hydroxylation. The resulting methyl and glucuronide conjugates are excreted by the kidneys. Elimination. Renal excretion of metabolites. Elimination half-life. Approximately 2 to 3 hours. Significantly shorter than clonidine, which has an elimination half-life of 6 to 10 hours. This shorter duration makes dexmedetomidine far more titratable clinically. Context-sensitive half-time. Longer after prolonged infusion. This matters in ICU settings, where dexmedetomidine may be infused for hours to days. Expect some accumulation with extended use, and delayed offset when the infusion is stopped after a prolonged course. Dosing. Loading dose. 0.5 to 1 microgram per kilogram, IV, given over 10 to 20 minutes. Many anesthesia providers omit the loading dose entirely. The reason? The loading dose produces the most significant hemodynamic effects: transient hypertension from peripheral α₂-B vasoconstriction, followed by hypotension and bradycardia from central sympatholysis. Giving the loading dose slowly over 20 minutes or skipping it dramatically reduces this hemodynamic perturbation. Maintenance infusion. 0.2 to 0.7 micrograms per kilogram per hour. ICU doses, up to 1.5 micrograms per kilogram per hour, institution dependent. Procedural sedation. Small boluses of 0.25 to 0.5 micrograms per kilogram. Clinical uses. ICU. Sedation. This is the primary FDA-approved indication for dexmedetomidine. For mechanically ventilated ICU patients, dexmedetomidine provides sedation that resembles natural sleep. Multiple landmark ICU trials demonstrated that dexmedetomidine-based sedation resulted in fewer days on the ventilator, less delirium, shorter ICU stay compared to benzodiazepine-based sedation. Dexmedetomidine preserves the respiratory drive. After extubation, dexmedetomidine-sedated patients breathe spontaneously, appear calm and relaxed, without the respiratory depression risk of benzodiazepines or opioids. Awake fiberoptic intubation. This is one of the most elegant uses of dexmedetomidine in anesthesia. The patient with a difficult airway who cannot be safely intubated after induction needs to be awake during the intubation. But awake intubation is extremely uncomfortable and anxiety-provoking. Dexmedetomidine provides anxiolysis, some analgesia, cooperative sedation with preserved airway reflexes, and preserved respiratory drive. The patient is sedated enough to tolerate the procedure, but awake enough to protect their own airway, and to follow commands such as taking a deep breath when you ask. This is the ideal drug for awake fiberoptic intubation when combined with topical local anesthesia of the airway. Monitored anesthesia care. Sedation, monitored anesthesia care. Dexmedetomidine provides sedation for procedures performed under local anesthesia. Colonoscopy, interventional radiology, ophthalmic procedures, where the patient needs to be comfortable but cooperative. AIRS protocols, enhanced recovery after surgery. Dexmedetomidine fits perfectly into multimodal analgesia protocols, reducing opioid requirements, reducing postoperative delirium, smoothing the perioperative course. Prevention of emergence delirium. This is the clinical application where dexmedetomidine works synergistically with ketamine. Dexmedetomidine has been shown to effectively attenuate the cardiostimulatory and post-anesthetic delirium effects of ketamine. Opioid-sparing anesthesia. Dexmedetomidine provides analgesic and analgesic-sparing effects, reducing intraoperative opioid requirements, reducing postoperative pain scores, reducing nausea from opioid use. Treatment of postoperative shivering. Dexmedetomidine markedly increases the range of temperatures that do not trigger thermoregulatory defenses. Neurosurgery. Dexmedetomidine reduces CMR02, cerebral blood flow mildly, and sympathetic activity, making it suitable for neurosurgical cases. It is also useful during awake craniotomy, where patient cooperation during cortical mapping is essential. And dexmedetomidine provides comfortable, arousable sedation during the mapping phase. Obstructive sleep apnea. Dexmedetomidine is useful in patients with OSA because it preserves airway muscle tone better than other sedatives and maintains the upper airway reflexes that protect against obstruction. Drug withdrawal management in the ICU. Both clonidine and dexmedetomidine are useful in preventing drug withdrawal symptoms following long-term sedation with benzodiazepines. The sympatholytic effect blunts the sympathetic hyperactivity of withdrawal, reducing heart rate, reducing blood pressure, reducing agitation. CNS effects. Dexmedetomidine decreases cerebral metabolic rate for oxygen, CMRO2, cerebral blood flow, mildly, sympathetic activity, significantly. EEG produces a pattern resembling natural sleep, stage 2 NREM sleep, sleep spindles, not anesthetic suppression. This is fundamentally different from propofol, which produces burst suppression at deeper doses, or benzodiazepines, which produce diffuse theta and delta slowing. The natural sleep EEG is why patients are so easily aroused, and why the sedation feels more natural to patients than GABA-mediated sedation. Critical exam fact. Amnesia is not assured with dexmedetomidine. This is one of the most important distinctions between dexmedetomidine and GABA-mediated sedatives. Propofol and midazolam produce reliable amnesia. You can count on the patient not remembering the procedure. With dexmedetomidine, the patient is cooperative and interactive. They can form memories. They may remember the entire procedure. This has major implications. If the procedure is painful or distressing, dexmedetomidine alone is insufficient. Patients can remain cooperative and interactive. This is a feature for awake intubation and awake craniotomy. But it is also a limitation for procedures where you want the patient to remember nothing. Cardiovascular effects. The cardiovascular effects of dexmedetomidine are biphasic, and understanding this biphasic response is essential for safe administration. Initial effect, minutes after bolus, peripheral α₂-B receptor stimulation, vasoconstriction, transient hypertension. This is mediated by α₂-B receptors on peripheral vascular smooth muscle. The blood pressure rises transiently, sometimes significantly, particularly with rapid bolus administration. Then the central effect dominates. Central α₂-A receptor stimulation in the locus ceruleus decreases norepinephrine release, sympatholysis, heart rate falls, blood pressure falls, cardiac output decreases. This is the sustained hemodynamic effect, the effect you manage throughout the infusion. The bottom line, heart rate decreases, blood pressure decreases, cardiac output decreases with sustained infusion. Loading doses can produce more hemodynamic instability. Slow infusion greatly reduces this. Many anesthesia providers omit the loading dose entirely, particularly in patients who are elderly, hypovolemic, or who already have low heart rate or blood pressure. The most clinically significant adverse effects of dexmedetomidine: bradycardia, hypotension, and rarely sinus arrest. Use with beta blockers. Caution: additive bradycardia. Use with calcium channel blockers. Caution: additive hypotension and bradycardia. Contraindications and cautions. Advanced heart block. Absolute contraindication. Dexmedetomidine may worsen conduction abnormalities. Severe bradycardia. Relative contraindication. Hypovolemia. Hypotension will be exaggerated. Volume resuscitate first. Respiratory effects. This is where dexmedetomidine has its most significant clinical advantage over all other sedatives. Minimal respiratory depression. At clinical doses, dexmedetomidine produces only mild depression of ventilation, even at doses high enough to produce total IV anesthesia. The respiratory drive is maintained. The response to CO2 is preserved. Spontaneous ventilation is maintained. At very high doses, loading dose of 1 microgram per kilogram, followed by 5 to 10 micrograms per kilogram per hour, dexmedetomidine can produce total IV anesthesia without associated depression of ventilation. This is a remarkable property. No other drug can produce anesthesia-level sedation while preserving breathing. The preservation of breathing provides a potential anesthetic technique for patients with a difficult upper airway who cannot be safely rendered apneic. Less apnea than opioids or propofol. Airway can still be obstructed with oversedation, particularly in patients with OSA or anatomically difficult airways. Always monitor. Do not become complacent because dexmedetomidine rarely causes apnea. MAC-sparing and analgesic properties. MAC-sparing, dexmedetomidine, significantly reduces the MAC of volatile anesthetics. Isoflurane, MAC reduced approximately 35 to 50% at clinical dexmedetomidine concentrations. This allows you to run significantly lower concentrations of volatile agent, reducing cardiovascular depression, reducing emergence time, reducing PONV. Opioid-sparing. Dexmedetomidine reduces intraoperative opioid requirements, reduces postoperative pain scores, reduces postoperative opioid consumption. Analgesic properties. Dexmedetomidine is analgesic but not anesthetic, an important distinction. It provides meaningful analgesia, particularly for somatic pain, through the spinal cord mechanism, reduction of substance P in the dorsal horn. It is synergistic with regional anesthesia, enhancing the quality and duration of nerve blocks when added to local anesthetic solutions or given IV perioperatively. Better for somatic pain than visceral pain, similar to ketamine in this characteristic. Reduces catecholamine release. Stress response is blunted. This contributes to the smooth hemodynamic perioperative course. Advantages. Comprehensive summary. Excellent sedation quality. Natural, sleep-like, cooperative, arousable, minimal respiratory depression, the most clinically significant advantage over all alternatives. Awake extubation. After dexmedetomidine sedation, patients can be extubated while still sedated. They breathe spontaneously. They maintain their airway. They are calm during the transition from ventilator to spontaneous breathing. Smooth emergence. No coughing. No bucking. No agitation on emergence in the properly sedated patient. Stable airway reflexes, preserved during sedation, important for OSA patients and for airway management. Decreased delirium, particularly in ICU settings. Dexmedetomidine is one of the few pharmacologic interventions shown to reduce postoperative and ICU delirium, a major driver of morbidity in critically ill patients. Less opioid required. Reducing opioid-related side effects, nausea, vomiting, ileus, respiratory depression. Useful in OSA, preserves airway muscle tone. Useful during awake craniotomy, cooperative sedation during cortical mapping. Treatment of postoperative shivering, effective and often underutilized. Attenuates ketamine emergence reactions, a valuable clinical combination. Adverse effects. Bradycardia, most common clinically significant adverse effect. Manage with glycopyrrolate for mild cases. Stop the infusion for severe cases. Hypotension, particularly with loading doses or in hypovolemic patients. Manage with fluids and vasopressors if needed. Sinus arrest, rare but reported. Cardiac arrest has been reported with severe bradycardia. Monitor continuously. Transient hypertension, with rapid bolus, from peripheral α₂-B stimulation. Reason to always give loading doses slowly or omit them. Dry mouth, anticholinergic-like effect from reduced salivary secretions. Taper rather than abruptly stop after prolonged infusions. Your top exam pearls. Before we close, the essential facts. 1. Alpha-2 to alpha-1 selectivity, approximately 1,620 to 1, the highest of any clinically used alpha-2 agonist. 2. 7 to 10 times more selective for alpha-2 receptors than clonidine. 3. Full agonist at alpha-2 receptors. Clonidine is only partial. 4. Mechanism. Activates presynaptic alpha-2 receptors. Inhibits norepinephrine release. Sympatholysis from the locus coeruleus primarily. 5. Sedation resembles natural sleep. EEG shows sleep spindles, not anesthetic suppression. 6. Patients can remain cooperative and interactive, easily arousable. 7. Amnesia is not assured. Critical exam fact. 8. Minimal respiratory depression, the defining advantage, preserves spontaneous ventilation even at high doses. 9. Biphasic cardiovascular effect, initial peripheral vasoconstriction, transient hypertension. Sustained central sympatholysis, bradycardia, hypotension. 10. Loading dose can produce transient hypertension. 11. Loading dose leads to transient hypertension. Sustained infusion leads to bradycardia, hypotension. 12. Reduces isoflurane MAC approximately 35 to 50%. 13. Opioid-sparing. Reduces intraoperative and postoperative opioid requirements. 14. Analgesic via dorsal horn, substantia gelatinosa. Reduces substance P. 15. Clinical uses. ICU sedation, awake fiberoptic intubation, MAC sedation, ERAS, awake craniotomy, prevention of emergence delirium, treatment of postoperative shivering, opioid-sparing anesthesia. 16. Contraindications. Advanced heart block, severe bradycardia, cardiogenic shock. 17. Use caution with beta blockers, calcium channel blockers. All can cause additive bradycardia or hypotension. 18. The clinical mantra. Cooperative sedation, preserves respiration, sympatholysis and analgesia, MAC and opioid sparing. Use smart. Infuse slow. Monitor HR and BP. Dexmedetomidine, a drug that provides analgesia without opioids, that preserves the airway and the respiratory drive, that allows you to extubate a patient who is still sedated and trust that they will keep breathing. Use it thoughtfully. Respect the bradycardia. Respect the hypotension. I'm Anesthesia Buddy. Stay sharp. See you in the next one.